Good morning or good afternoon, everybody. Thank you very much, John. Thank you very much, Juha and Professor Bill. I present some experience of the parent vessel occlusion test to treat the fusiform aneurysm. I don't know why it don't work.
Okay, there it goes.
Yeah. Test occlusion. Why test occlusion with coil and not balloon? Because one case, so many years ago, I have a rupture of the artery with a balloon. I decided in some case it's not safe to put one coil and test anatomical test or clinical test. The truncal aneurysm is originating in a straight vessel, not in the bifurcation. When it's chronic, you are a thrombus, normal. Also, in acute dissecting, it's possible to have a dissecting aneurysm and truncal aneurysm and subarachnoid hemorrhagic. And the blister-like also sometimes is the origin of hemorrhagic, and it's very difficult to coil in this blister-like, and you need to close the parent vessel. This is example to 10 patients. It's not proper to use a balloon or a stent or remodeling in this case. 4 aneurysm is a giant anterior circulation and 6 is posterior circulation. Some examples. It's posterior communicant artery in the junction of the basilar tip, giant aneurysm. This is microcatheter. This is the posterior cerebral artery. I decided to push some coils and testing the collateral circulation. Another case, giant basilar aneurysm is treated in 3 times by coiling, and every time is the regrow the neck of aneurysm, and finally I decide to put in the third session to put coiling and close the artery, the basilar artery in this point. This is the control. You are the basilar trunk, the coil, the collateral circulation here. And this is the totally cure of this aneurysm. Another complex aneurysm, distal basilar aneurysm, AP view, lateral view, fusiform. I decided to treat with balloon plus coiling. I stop the flow, the collateral circulation, and totally occluded without symptoms, major symptoms. Woman, 24-year-old, acutely dissecting aneurysm in E1, is rebleeding 3 months later, and this is the time I perform the embolization. I decide to close aneurysm and E1 and to occlude totally this aneurysm. This is an example that present the last week. It's a 2-year-old child with intraventricular hemorrhagic. I have a Fusiform A2 aneurysm. This is AP view, this is oblique view. Sorry, lateral view, projection. I decide to put the coil in the neck. I look the stagnation of the contrast. I decide to occlude it, the aneurysm in the neck, and you have the collateral leptomeningeal anastomosis, and occluded and 3-mode control asymptomatic. Other dissecting aneurysm, 52-year-old, acute hemorrhagic, MR, axial view. This is the dissection, this point. Some of the time, many endovascular techniques discuss to put the stent here. No, I think it's possible. It's not, I prefer the solution to occlude it, this vessel, because this vessel is broke, is dissected. Another aneurysm dissecting in the origin of the pica. I decide to occlude it, and you are the with coiling. You are the collateral leptomeningeal anastomosis in the cerebellum without ischemia. This is the first example of the posterior communicant and basilar junction aneurysm, giant. This is the occipital cerebral posterior and occipital artery, AP view. I decide test occlusion with coiling. This is the microcatheter inside the sac. This is the coiling. Only 2 coils. This is a thrombus, and this is the collateral leptomeningeal anastomosis, total occlusion of the aneurysm. Other fusiform distal aneurysms in the pica, dissecting aneurysm, also is bleed. Navigate. It's better to close this vessel. To use the balloon here is dangerous. It's dangerous. Sorry, the balloon or the stent, because it's very fragile. The wall of the vessel in this part. Only with microcatheters you put some coils. Also another blister-like aneurysm in the superior cerebellar artery. Very small with a spasm. Coiling and occluded the aneurysm and protect the patient. This is a patient, 70-year-old, with aneurysm with mass effect and bleeding, fusiform or serpenginous aneurysm of the middle cerebral artery. You are here the spasm. you are here, the collateral anastomosis. I treated in acute phase in Colombia by myself. I decide to occlude it. This branch, just here, this is the mark. We are the edema around the aneurysm. And the patient is a convulsion, chronic convulsion, and occluded, and the patient is still well. This is a previous study with another doctor with technique, Salupka, Moret, Mawat, Dion, 8 case, 2 case. This is the complication of this series. Many cases have some problems. Transitory, hemianopsia, hemiparesia, facial palsy, dysmetry. Moret and Mawat and Shahrukh Khan did in posterior cerebral aneurysm artery. Is safe to occlude the artery. In my experience, I don't have a complication of this pain case, and the result is very, very good to the patient. Thank you.
I'm sorry, Lois. Okay, thank you very much. I guess
Thank you.
I made the mistake is not unmuting myself. Okay, any comments or questions? Yuha, do you have any comments?
Yeah, they look terrible cases, whatever you are doing. Extremely difficult cases. So desperate cases need desperate treatment.
Luis?
Yes?
Do you use some monitoring like MEP, SEP when you're testing the coil of the aneurysm?
In posterior or basilar,
Mm-hmm.
no, it's
No.
impossible. It's impossible. Mm-hmm. And in the side, it's impossible. It's by general anesthesia. The clinical test is, I think, is well when the patient tolerates the clinical test. The electrophysiological test, I don't have many good effects with my neurologist. I don't know why. I don't understand very well. I don't have the experience with you are the neurosurgeon. I think it's very important. Probably it's interesting, but in some case, and the only for me is the anatomical collateral analysis with double catheter. You have one catheter inside with treatment, and you have another catheter control the collateral anastomosis. Mm-hmm.
Okay. So do you have some delayed ischemic condition patients?
No.
No. Okay.
Never. And the patient mm-hmm. with the blister like aneurysm, mm-hmm. I don't use the antiaggregation. Yeah, never. This is one of the reasons in some special case, it's preferable to analyze. It's better to sacrifice the vessel or to put some flow diverter because you integrate the patient. This is the question. The blister light.
Yeah.
Okay, very good. Any more comments, questions from the panelists?
Yes, this is Victor Hugo from Mexico.
Welcome, Victor.
Hello, how are you? Very nice lectures. The rupture of the aneurysm that you have shown us was impressive, but the most impressive is how you resolve the rupture, putting muscle and the aneurysm. How the patient did, how was the recovery of this patient in the post-operative state, Dr. Juha?
Excellent, excellent, excellent. Yeah, he made wonderful recovery. Even was old man, 75 or something, with fragile vessels. But, when of course you understand that kind of situation in an operation room, you are dissecting the annulus and suddenly you have 3 holes in the carotid. So the annulus space is broken because it was fragile. I have looked many times this video and I didn't put much pressure, but much. So it was good solution. So you have to have that kind of tricks, many kind of tricks. I will show that kind of tricks in future, many, how to manage desperate situations. Of course, sometimes you may lose, sometimes you may do good recoveries. You may save the situation. Just came in my mind. This old trick to use muscle. So I have done it several times in neurosurgery, and muscle is extremely useful in sealing the rents. And you have to just put find the way how to put muscle on the bleeding place on the artery. That's I want to show videos which I could show beautifully edited videos without any bleeding and without anything special, but each you have to show how to manage difficulties.
Okay.
Really useful, really useful. It's very useful to see how to resolve these big problems. Thank you so much, Professor
Thank you,
Juha.
Victor. Thank you, Victor.
Okay, more questions, comments from the panelists? Okay, if not, okay, Juha, what do you have anything in mind for next week, Juha?
Next week, same time, welcome. So Hugo will speak about contralateral approach. He made his PhD in Helsinki. And he will speak about MCA and then ophthalmic aneurysm, contralateral approach. I think this and bifurcation aneurysm. So
Okay.
it will be interesting talk. I will show also some videos related to that.
Okay, very good.
Then we continue every week. We continue with different sides of aneurysms, speaking now about carotid aneurysms, going upwards up to carotid PCAM, choroid, and then carotid bifurcation, and then we take the next side. So we make special evenings for every side of aneurysms.
Okay, very good. Okay, I'd like to thank Hugo for helping me moderate, and also to Ben, who does translation in Chinese. And I'd like to say welcome to the Chinese medical community. Fun Yi Nei. Okay, Juha, we'll see you next week.
Thank you very much.
Bye-bye.
Thank you very much.
Bye-bye.
Very good.
Bye-bye. Thank you.
Yeah. Yeah, thanks,
Bye-bye.
Ben. Thank you very much.
Thank you.
Bye-bye.
Thank you.
Oh, Selfie, you made it.
Yeah, thank you.
for invite.
Yeah, if I'd like you to meet, I guess Ben probably left. Busy guy, went from one conference to another. Are you in the OR now? Sophie, are you in the OR?
Just finishing, but I'm still on call, so still waiting.
Okay. Oh, okay, very good. I think you guys had Yuha. Didn't you have Yuha speak at your webinar one week? Okay.
And we're looking forward for Professor Bingsu for the next webinar this Sunday.
Yes. Oh, great, great. So we'll see you then.
Yeah.
Okay.
Okay, Yuha, thanks a lot, and we'll see you.
Thank you.
Yeah,
I
just got to study that WeChat, get to know it well.
Ivan will teach you.
Yes, please let me hear from you. Please let me hear from you. It's very important.
No problem.
Okay, see you. Bye-bye. Bye-bye, everybody.
Bye-bye. Bye-bye.